Hello, my name is Steven Horwitz, and I'm a medical oncologist at Memorial Sloan Kettering Cancer Center, and I really focus on the care or studying new therapies for patients with T-cell lymphoma. And today I'm going to talk about peripheral T-cell lymphoma, really with an emphasis on upfront therapy and looking at CD30 expression. So just as a way to level set or think about this, this is some population-based a registry from Sweden, which I think gives us a good sense of where a starting off point is for standard chemotherapy for the more common subtypes of peripheral T-cell lymphoma. So the more common ones we see in the West are anaplastic large cell lymphoma, either ALK negative or ALK positive, angioimmunoblastic T-cell lymphoma, and peripheral T-cell lymphoma not otherwise specified. Most of those subtypes, with the exception of ALK-positive ALCL, have a relatively poor prognosis. And that means here, where almost all these patients had combination chemotherapy or CHOP-based therapy, the majority of patients either don't respond or will relapse within the first few years after initial induction therapy. The one somewhat outlier for that is ALK-positive anaplastic large cell lymphoma, where those patients tend to be younger, have better prognostic factors, and the majority of them, 60% or more, will be cured with combination chemotherapy. And then I think when we look at historically progression-free versus overall survival, we sort of can highlight the lack of effective therapies at relapse. And that's where the overall survival curve often mirrors the progression-free survival curve. And I'll show you some new therapies where I think that's changing, but this is a good starting off point. So in ways of improving upfront therapy, without going into detail, there have been a number of attempts to approve upfront therapy to increase the cure rate for peripheral T-cell lymphoma. Most of those have been unsuccessful, or at least not showing clinically significant improvement. The one exception is the addition of brentuximab vedotin to a CHOP backbone. And I'll talk about that data for a minute. So this is the Echelon-2 study that was published a few years ago now, which looked at taking patients with CD30 expressing T-cell lymphoma. For inclusion in the study, it was 10% or more expression on the tumor cells or the lymphoid infiltrate. We'll go into more detail in terms of is there or is there not a cutoff of CD30 expression. That was added not because it was known to be a lower limit of activity, but we wanted local review to be accurate. So it was felt that 10% or more, the local pathologist could accurately call that, and those patients could be eligible without the time delay of a central review. So the study enrolled untreated patients with CD30 expressing T-cell lymphoma of the subtypes you see there. Importantly, in this study, the study was designed to look at the overall population and the anaplastic large cell lymphoma population independently. So that was benchmarked to be about 70% or 75% of patients to have anaplastic large cell lymphoma. That's the universally strongly CD30 expressing lymphoma where the preliminary data was greatest for brentuximab. And then patients were randomized in a double-blinded fashion to receive brentuximab vedotin plus CHP, dropping the vincristine because of concerns about overlapping neurotoxicity, or standard CHOP. And the primary endpoint was progression-free survival. These are the patients who were accrued. So you can see that the majority of patients down here had stage 3 or 4 disease, as is typical for peripheral T-cell lymphoma. About 70% of patients overall had systemic anaplastic large cell lymphoma as it was designed. And the median age was 58. So that's probably a younger than average population, probably because of the increased inclusion of anaplastic large cell lymphoma. I think the other thing to point out bolded here is that the other subtypes of T-cell lymphoma, and we'll talk about this, peripheral T-cell lymphoma not otherwise specified, or angioimmunoblastic T-cell lymphoma, were not pre-specified to be looked at independently. They weren't powered for independent analysis, and they were not balanced between the two arms. We'll talk about that as we look at that data. So this is the 5-year updated data. So in the initial presentation and then the updated data, there was a significant improvement in progression-free survival for brentuximab vedotin plus CHP over CHOP, and that translated into an overall survival benefit. I think the other thing I like to point out here is sometimes in T-cell lymphoma, we think about the value of adding to a chemotherapy backbone because the results with CHOP alone are really inadequate for many patients. But at least in this prospective randomized study, and we don't have a lot of that data in T-cell lymphoma, the CHOP arm did okay. So the median progression-free survival from CHOP was just about 2 years, but over 40% of patients were progression-free at 5 years, and the median overall survival was not met at 5 years in the CHOP alone arm. So even though BV added, CHOP here did cure a significant number of patients. I think the other thing that led to the benefits of this therapy was there was no significant increase in toxicity. So if we just look at adverse events, the teal bars being brentuximab, the purple bars being CHOP, the darker shades are grade 3 to 4, and the lighter shades are grade 1 to 2. If you look sort of across the board, there was really no significant increase in toxicity by adding brentuximab, with the exception of diarrhea was more frequent in the arm with brentuximab and without vincristine. But particularly hematologic toxicity was the same, and neuropathy was very similar. So that was the top line data. When we look into the other subsets, and this question comes up a lot with peripheral T-cell lymphoma unspecified or angioimmunoblastic T-cell lymphoma, I think the interpretation is much less clear. For PTCL NOS, the median is greatly increased with brentuximab plus CHP, but the curves come together at about 3 years, and there's wide confidence intervals. Overall survival, again, BV-CHP sits above the CHOP curve, but no significant difference in wide confidence intervals. For angioimmunoblastic T-cell lymphoma, the data, if anything, is even a little more puzzling, as the CHOP arm did quite well with a median progression-free survival of about 4 years. We really don't have data like that for CHOP with AITL and other settings, and it's really not clear exactly why this population did so well with CHOP. When you look at overall survival, while those groups both did fairly well, there's really no difference that can be seen between BV-CHP and CHOP. So I think conclusions from this, the easy conclusion is anaplastic large cell lymphoma, which could be looked at independently, had an overall survival benefit with brentuximab plus CHP. That's the standard of care really in the US and around the world. I think for other CD30 expressing T-cell lymphomas, it becomes a little more in the eye of the beholder. It is on label for other subtypes of T-cell lymphoma, adding brentuximab to initial chemotherapy. And those patients were part of the intent to treat analysis, which led to an overall survival benefit. However, when we look at those subsets, again, unplanned, not independently powered, it's really hard to tell how much the brentuximab is adding to those patients. And because it doesn't increase toxicity, I think it's a reasonable option to add, but maybe not instead of other studies if there's other novel approaches that we want to look at. So other ways to improve upon CHOP. I think the other efforts that look like they may do better is really dose intensification of chemotherapy. So this is older data now looking at adding etoposide to a CHOP backbone. So really giving increased chemotherapy sometimes in an every 2-week cycle. So dose-dense, dose-intense chemotherapy. And this was a subset analysis from a number of studies done in Germany looking at patients with aggressive T-cell lymphoma. When they pull out the T-cell lymphoma patients, which are about 10 or 15% of overall, if you look at the younger patients, we see this benefit in terms of event-free survival for adding etoposide to CHOP. Now, when you look at who was in that study, most of those patients were also anaplastic large cell lymphoma, similar to the Echelon-2 study with brentuximab. And when you look at the toxicities there is a toxicity cost by adding etoposide, mostly in terms of hematologic toxicity. And in the B1 study, which were the younger patients, that didn't really translate into increased risk of infection or other clinical consequences. When you separate out the older patients, you do see increased toxicity, and that does lead to increased clinical consequences, which kind of erodes or abrogates any potential benefit of adding etoposide. So it looks like adding etoposide may increase a bit in the efficacy, but there's a toxicity cost, and how that affects the patients determines whether we get any benefit in event-free survival. I think the other way of intensifying chemotherapy that is commonly done in T-cell lymphoma is upfront transplant or consolidating first remission with auto transplant. There's no randomized studies to support that. This is the largest prospective study we have, often referred to as the Nordic study. So this was taking patients with newly diagnosed T-cell lymphoma of the subtypes ALK-negative ALCL, angioimmunoblastic T-cell lymphoma, PTCL NOS, or enteropathy-associated T-cell lymphoma. Those patients got CHOP plus etoposide every 2 weeks if they were under 60, CHOP if they were over 60, and patients who responded partly or completely were consolidated with high-dose therapy and auto transplant. So if you just look at the 5-year overall and progression-free survival, while it's not a randomized study, it does look like that's better than what we see with historical controls, again, with all the caveats of this is a clinical trial population. And when we look at the different subtypes, and maybe I'll just focus down in the bottom right on progression-free survival, we see if there is benefit, that benefit may not be evenly distributed among the different subtypes. So if anything, the patients with ALK-negative anaplastic large cell lymphoma fare the best with intensified induction chemotherapy followed by auto transplant, and still reasonable progression-free survival for angioimmunoblastic T-cell lymphoma, less good results for PTCL NOS or enteropathy-associated T-cell lymphoma. What about then BV plus dose intensification? So if we take the two approaches that may be better, can we add them together, and what does that look like? So there's a little bit of data for that. In the Echelon 2 study, the primary endpoint was progression-free survival, and patients could be consolidated with transplant based on investigator choice. So this was not a randomized or a pre-specified endpoint, but we did go back and look at the patients who got auto transplant in first remission. So if you look at the patients with ALK-negative anaplastic large cell lymphoma who achieved a CR to BVCHP, if they had consolidative transplant or not, it looks like there's a benefit or a potential benefit for consolidative transplant with a hazard ratio shown there. If you look at the patients with PTCL NOS or angioimmunoblastic T-cell lymphoma who had a complete remission and were consolidated with transplant, again, the numbers get fairly small here, but it does look like there may be a benefit, hazard ratio 0.46, but pretty wide confidence intervals with these smaller numbers. But we look at this to say possibly adding transplant and BV may improve the progression-free and thus overall survival even further. I think the other study that's looked at that was a study done in France, kind of modeled off Echelon 2, but looking at a more intensified approach for enteropathy-associated T-cell lymphoma. So many of you may know this is the intestinal T-cell lymphoma that's associated with celiac disease, and historically these patients have had very poor outcomes. I showed you some of the data with the Nordic study. So these patients are usually, or their tumors are usually CD30 expressing. So the investigators in France took BVCHP, the same experimental arm that was used in the Echelon 2 study, and treated patients for 4 cycles. They then did an intensification course with etoposide and methotrexate, and then patients who were non-progressors were consolidated with a beam auto transplant. Again, a non-randomized study, but the results look fairly good. If they look at the end of all chemotherapy, almost 80% of patients had responded, and over 70% of those were in complete response. There were a few cases of patients with early progressive disease. And when we look at the progression-free and overall survival curve, if we think back to the Nordic study, which used CHOP etoposide followed by auto, those progression-free survival curves were just under 40%. So again, comparing different studies with all the caveats of that, it looks like this approach results in higher response rates than we've previously seen with enteropathy-associated T-cell lymphoma, and maybe better results with progression-free or overall survival. The other approach that's looked at that is something that's been colloquial called the TMAC study. So this was led out of City of Hope by Alex Herrera as a multi-center study that really looked at intensifying chemotherapy and brentuximab in a number of ways. So if you follow me here, patients were given an induction with CHEP, so cyclophosphamide, doxorubicin, etoposide, and prednisone, dropping the vincristine from CHOEP and adding brentuximab. Patients who responded were then consolidated with high-dose therapy and autotransplant, and then patients could get maintenance brentuximab to get a total of 16 doses if they tolerate it from a neuropathy standpoint. Now, again, this is a phase 2 study without a comparator arm, but with this very intensified approach, we do see high rates of response. So if you look at the overall response, it's over 90% for most of the subtypes, a little lower for PTCL NOS, and the complete response rates, again, are quite high, ranging from 82% for AITL, 94% for anaplastic large cell lymphoma, and again, some lower responses for PTCL NOS. And if you look at the time to event curves there, progression-free survival and overall survival, you see that the transplanted patients really do quite well. So the patients who could tolerate this whole package of intensive therapy look like they do better than what we've seen with some of the other studies. And this study is being expanded to look at in a larger data set. So if we think about sort of what we got or adding maximalist therapy for patients with untreated T-cell lymphoma, I think we see that if you add brentuximab and intensification, adding etoposide, adding transplant, or both, we do see some clues that there are a subset of patients that maybe benefit from those very intensive approaches. Those tend to be the younger patients who don't have adverse consequences from the increased hematologic toxicity, but there is a maximalist approach that looks like it can cure some patients. I think short of that, we need to look at other strategies. So I'll talk a little bit about CD30. A question comes up a lot is when do we add CD30-directed therapy in peripheral T-cell lymphoma? And I'll kind of walk through what data we have that may help guide therapy. So CD30 expression in T-cell lymphomas other than anaplastic large cell lymphoma. So anaplastic large cell lymphoma, universally strong CD30 expressing, high rates of response to single agent brentuximab. When we look at the other subtypes, the data gets a little bit unclear. In some older looks, this is a 2006 study here at the bottom where the cutoff was 30% of the tumor cells having CD30 expression and looking for higher levels of expression. When we look at PTCL, NOS, or AITL, very few patients have high levels of CD30 expression or high levels of intense expression. When you loosen that criteria, and here they just cut it down to 25% of the tumor cells and did an IHC score and looked at sort of moderate or high expression, the numbers go quite a bit higher. And I think this is something we see in T-cell lymphoma. Part of the rates of CD30 expression are dependent on how hard you look. But you do see that there are relatively frequent patients with CD30 expression that really span different subtypes of T-cell lymphoma. In the Echelon 2 study, I think what we see was representatives of what we see with these diseases. So you had to have 10% by local review for inclusion, and you'll see that patients with angioimmunoblastic T-cell lymphoma tend to have relatively low rates of CD30 expression, kind of in that 10 to 30% range. PTCL NOS is a little more all over the place, and you will have patients with low CD30, but you also will occasionally have these patients with 80 to 100% CD30 expression. That's almost never seen in angioimmunoblastic T-cell lymphoma. If you look at that based on response, I think what comes out is probably CD30 matters, but there's no true guiding cutoff in terms of who responds. So if you look here on the left, patients with PTCL NOS, and you look at their patients in CR, PR, progression of disease as their best response, you see that whether patients had low or high expression, they tended to respond, though the majority of patients with high expression responded. Angioimmunoblastic T-cell lymphoma, again, you see relatively lower rates of CD30 positivity, but no clear differential between who's likely to respond and who's not based on CD30 expression. I think we have some learning from mycosis fungoides. So this is a different disease, more indolent, but a disease where we've been able to look at multiple biopsies and sort of characterize the CD30 expression a little better. This cartoon comes from the Alcanza study, which was a randomized study treating patients with brentuximab or a standard therapy with mycosis fungoides. And if in that study, all patients had at least 2 biopsies. And if you look at the biopsies within individual patients, what you can see here, sort of shown by the blue or the green, is that within a single patient, different sites may have very different levels of expression of CD30. So there's a lot of heterogeneity in this disease, and we think probably in PTCL NOS in terms of level of CD30 expression. This just shows graphically in this plot what the actual CD30 expression levels were in that study. So the lower number is the lowest level of CD30 at any biopsy, and the top is the highest number. And if you look at in the Alcanza study, a lot of patients had really widely divergent CD30 expression between their 2 biopsies, and then there's a group that had less divergent. If you look at that in terms of response, I think what you get is sort of a trend that CD30 probably matters. So if you look at CD30 min, these are the rates of response. So if your CD30 minimum was less than 10%, still a fair number of those patients responded, shown by the solid circles here. If your CD30 max was very low, maybe a little less frequent rates of response. And you can look at that numerically here, that patients with CD30 min less than 10%, so the lowest CD30 expression on any biopsy of less than 10%, still had a 40% response rate, but maybe not quite as good as those who had higher levels of CD30 expression. Certainly nothing that's a cutoff for excluding the possibility that you'd get a response to brentuximab. This is a figure from a study we did with Stanford with mycosis fungoides. So just to walk you through it kind of quickly. So these are patients with mycosis fungoides, all had multiple skin biopsies, and those biopsies had multiple cuts. And we looked at the CD30 min and the CD30 max. The blue figures are those patients who responded. The red figures are non-responders. So there was no cutoff that excluded activity. But if you look at patients where the highest CD30 on any biopsy was 5% or less, those patients had a lower likelihood of responding, not 0, but a lower likelihood of responding than those patients who had a little more CD30. So I think when I think about CD30 and T cell lymphoma, the first thing is that it's heterogeneous and your one slide IHC may not be reflective of everything going on. ALCL is universally strongly positive, and then we see this variability in all these subtypes. How likely or what the percentage of positivity is really based on how you describe that. If it's any CD30 positivity, many patients have at least 1 or 2%. If you define your cutoffs as 25 or 30%, you get a little less CD30 positivity. There does appear to me to be a correlation with CD30 expression in response to brentuximab, but that response is modest. So we get by far the best responses in ALCL, which are strong, universally CD30 expressing. And when we've tried to look for lower levels of cutoff, at very low levels, there may be a lower likelihood of response, but we've never been able to find a level where there's no response. And we do all have patients who are CD30 negative who have responded. And maybe some of those were patients where if you took a different biopsy from a different site, you might see a very different level of CD30 expression. So if we look at relapsed PTCL, we have a range of therapies that have activity. There's really no one clear best therapy. And I think something that's evolved over time is our understanding that in earlier days when we were studying treatments across the board in T-cell lymphomas, we saw response rates overall that tended to be in the 25 or 30% range. But as we get more sophisticated and look at subtypes, we see that there's a lot of variable response by subtypes. And this just shows that in a table of some of the standard therapies. When we look at brentuximab in relapsed PTCL, and this is data from the Echelon-2 study, where in long-term follow-up patients who relapsed, we recorded who received brentuximab and how they responded. What you can see is that patients who had previous BV as part of their initial therapy had really the same rates of response and likelihood of response as those who just had CHOP alone. So it looks like retreatment with brentuximab is reasonable in patients with CD30 expression. The other thing, learning that's been done a lot in T-cell lymphomas over time is our understanding of the biology underlying the different subtypes has really increased. Most particularly, we now really understand the biology of angioimmunoblastic or follicular helper T-cell lymphomas that really develop on this background of epigenetic dysregulation. And then there's some other signaling pathways that can be targeted. And this is just starting to make its way into therapeutic choices. So to show that if you look at genetic profiling, this is a larger series of patients with peripheral T-cell lymphoma unspecified from Japan. The most frequent mutations when they did genetic profiling were mutations in epigenetic regulation, and then almost as frequent in tumor suppressor genes. And that kind of translates into some of our epigenetic therapies. So it's not really on target like CD30, but there is a correlation. And if you look at epigenetic therapies like azacitidine, the response rates are much higher. This is an early clinical series in angioimmunoblastic or follicular helper T-cell lymphoma than in PTCL NOS. We did a retrospective look where we tried to correlate mutations in epigenetic modifiers characteristic of follicular helper T-cell lymphoma patients and responses to histone deacetylase inhibitors. And we see almost twice the rates of response and complete response in patients with follicular helper subtype or those characteristic mutations, as opposed to other patients with T-cell lymphoma who don't have those mutations or don't have a follicular helper phenotype. This is data from valemetostat, which is another epigenetic modifier from the Valentine study, which was the phase 2. And if we just look at the PET-based responses on the right, while we see very nice responses across the board, the most frequent responses are those in angioimmunoblastic T-cell lymphoma, which we know develop on this background of epigenetic dysregulation, though also responses in other subtypes. This is a larger data set with the oral azacitidine. This was a confirmatory study done in France. Again, just confirming that azacitidine does appear to have a reasonable response rate, not quite as high as was seen in the preliminary study in angioimmunoblastic T-cell lymphoma, and that the duration of response or progression-free survival was better than with some standard therapies. I think we see some similar data from duvelisib, which is a PI3 kinase inhibitor, which we don't think would necessarily be subtype driven, but we see overall from the preliminary data from the phase 2 study about a 50% response rate in T-cell lymphoma, which is better than a number of our previous therapies, but particularly high response rates in angioimmunoblastic T-cell lymphoma and relatively low response rates in anaplastic large cell lymphoma. And we're starting to understand a little bit why the responses may be lower in ALCL. And kind of a similar data we see from an early look we did at ruxolitinib. So looking at targeting the JAK-STAT pathway in T-cell lymphoma, patients that had that had mutations in the JAK-STAT pathway or elevated phospho-STAT3, sort of evidence of pathway activation, were here in cohorts 1 or 2, and those were really the patients who are most likely to respond, and much higher response rates than those who had neither. And what I just show here on the right is those responses really cross subtypes, so it's more of a marker of biologic vulnerability to JAK inhibition than something that highly correlated with one specific subtype. So I'll just end there with a very quick look at therapies under development in relapsed T-cell lymphoma, and just say we're starting to understand better how to match therapies to individual patients, and we look forward to that being part of studies going forward. Thank you.